So I just want to first of all thank everybody for joining us today for Children's Health in Focus, conversations we're holding with experts on timely and important health-related topics. I'm Arturo Brito, President and CEO of Children's Health Fund. Today's topic is the end of the COVID-19 public health emergency. We ask if this is a looming nightmare. Some of us think it is for a lot of children and families around the country. At Children's Health Fund, our vision is to ensure that all children receive the health care they deserve and need to thrive and succeed. We lead a national network to bring comprehensive health care to children growing up in under-resourced communities, and we advocate for the health and well-being of all children. Children's Health Fund was founded more than 35 years ago, and today we lead a national network of 25 partners in 15 states, Washington, D.C., and Puerto Rico. Our partners provide comprehensive health and wraparound services to children and families in some of the poorest and most remote areas across the country, from urban to rural. They provide this care through a fleet of more than 50 mobile medical clinics, connect via telehealth, and have a presence at more than 400 schools, homeless shelters, and other community sites. So while today marks the official end of the COVID-19 pandemic, public health emergency, the unwinding from this crisis has already begun in many areas of the country. We know that COVID-19 is still with us. The last I looked, there were more than 200 deaths per day in this country from COVID-19. And that many of the measures that were put in place at the beginning of the pandemic were and continue to be vital to ensuring the health of so many. We're concerned about how the end of the public health emergency will affect the availability and affordability of tests, vaccines, telehealth, and so much more. And how these changes will impact children is particularly of concern to us, particularly those children living in low-income households and remote or hard-to-reach areas of the country where accessing healthcare was a challenge pre-pandemic. To start with, we're concerned about how many Americans may lose their health insurance coverage. By many estimates, as many as 15 million Americans could lose coverage. 1 in 3 of those are predicted to lose coverage are Latino, 15% Black. And more than 5 million children are predicted to lose coverage through Medicaid and the Children's Health Insurance Program. So joining me today, we are fortunate to have with us Dr. Kemi Ali and Ms. Ali Gardner. Dr. Ali is the Chief Executive Officer of the Henry J. Austin Health Center, a Children's Health Fund National Network partner. Welcome, Dr. Ali. She's based in Trenton, New Jersey. She's been a pediatrician for the center for 20 years, and I've known her for many of those years because I worked at the New Jersey Department of Health before, and we connected there on many occasions. And Ms. Gardner is a senior research associate at the Center for Children and Families at the Georgetown University McCourt School of Public Policy. The Georgetown Center has been a leader in tracking and reporting on the unwinding. Before we jump into our conversation, a couple housekeeping items. First, we ask that you all keep yourselves muted throughout to avoid any background noise. And if you do have any questions, we welcome them, and we ask you to post them in the chat. I'll be monitoring them throughout the session, and we'll get to as many as time permits. So with that, Dr. Ali, I'm going to start with you to tell us a bit more about the Henry J. Austin Health Center and the type of patients that you see and serve at the center.
Yes, so thank you so much for the invitation to speak with everyone today. So Henry J. Austin Health Center is a federally qualified health center. We are located in Trenton, New Jersey. We see approximately 18 to 20,000 patients a year, and a third of our patients are children. We primarily see individuals that are African American. About 53% of our patients are African American or Black, and about 30% are Latino and prefer to speak in a language other than English. A good majority of our patients are impoverished, so they fall below 200% of the federal poverty level. We have 8 locations in and around the city of Trenton, and we also have our mobile health unit that is sponsored and supported by the Children's Health Fund. So we're very proud of that. And then, as I mentioned, we also have a significant amount of our children, as I said, that are about 30% of our individuals are children.
Yeah, thanks for that. And having been there a number of times to the center and having worked in Trenton, capital New Jersey, I think that people should understand that what you do there, the number of people you serve, you're truly an oasis for that community, because there aren't other accessible health care services in the immediate area. And the quality that you provide there is like, it's just top of the line. So I encourage people, if they ever want, to visit your center and so many of our other partner sites throughout the country. Ms. Gardner, could you tell us more about how healthcare coverage for low-income people changed during the pandemic, and how Medicaid or CHIP rules that are currently changing or have already started to change around the country could start impacting those children?
Yeah. So as the COVID pandemic really picked up speed in early 2020, Congress passed the first of many COVID-related legislations, being the Families First Coronavirus Response Act. And as part of that legislation, Congress put a freeze on Medicaid enrollment, which prohibited states from disenrolling anyone that was enrolled on Medicaid as of March 18th, 2020. If the state wanted to receive enhanced federal funding. And it was a pretty substantial increase to all Medicaid funding. And so all states followed that prohibition. So for about 3 years, everyone who has had Medicaid coverage or enrolled in Medicaid coverage has remained with healthcare coverage. And to give you a scale of what the effect of that policy was, is starting in February 2020 to December 2022, Medicaid and CHIP enrollment grew by 29%, and around half of those individuals enrolled are kids. So I think one thing we've really learned through this is that Medicaid has proved itself as a safety net program and really showed its value in times of crisis, and that it's there for low-income children and families to support them, especially during times of economic downturn. And then as part of the Consolidated Appropriations Act that was passed at the end of last year, the maintenance of effort requirement, or that disenrollment freeze, was delinked from the federal public health emergency, which is what ended today. So as a result, states were allowed to begin terminating Medicaid coverage on April 1st. And unfortunately, we've already seen a pretty stark impact, particularly on kids. We're getting a slow trickle of data from the first few states that have begun disenrollments, some more positive than we've thought. So Arizona, for example, we've actually seen more people that maintained coverage than were disenrolled in coverage in their initial months of renewal. But then you have a state like Arkansas, which released its data on Monday, and almost 30,000 kids lost coverage, primarily for procedural or administrative reasons, not because they were ineligible. So this is going to play out very differently across states, but kids are really going to be in the crosshairs.
Yeah, thank you for that explanation and helping clarify. That includes some of the confusion that is already ensuing, right? And with that, that actually segues a little bit into the question I have for Dr. Ali. That while she works in a state that has been ahead of the curve on increasing coverage through Medicaid and CHIP, even before the pandemic, there still could be an impact of this unwinding on the children and families that she oversees the center to provide care for. Do you want to maybe say a few things about that, Dr. Ali, about how that might be impacting, or what you may already be seeing? I don't know.
Yes, and I think it's a little too early to see the impact for us, as it started in April. But what we're really concerned about is just as Ms. Gardner said, those children that will lose their coverage. And it's been so important to the children and the families that we've seen over the last 3 years. And one of the things that has been quite noticeable for us as an organization, when we look at our trends of individuals that have insurance, we could see the trend of those going up with Medicaid and then those going down. And there was this point of intersection where actually more children had Medicaid than those that were uninsured. As you mentioned, we are very fortunate in the state of New Jersey. There's legislation that's passed to cover all kids with insurance, whether documented or undocumented. That is great. But now our fear is that there will be this confusion. And so that children that could be eligible, if their parents are not eligible, they will be confused and think that their children are not eligible. And so really, how are we getting this message out that the children may still be eligible even if the parents are not? And that is really important. And as we know, healthy children really lead to thriving children in so many different ways. And healthcare is an important piece of making a healthy, thriving, successful adult. And so, yeah, this is really important and something we're really trying to be proactive around.
Yeah. So, okay. So time will tell and we'll see. But I think at the very least, what we're saying is there's gonna be a lot of confusion, and some people may fail to enroll because of that confusion, and which is a problem. We know that health insurance doesn't guarantee quality health care, but it's the entryway into it. And we're going to talk more about that a little bit later. Right now, I want to go back to what today officially marks as the end of the public health emergency or the COVID-19 pandemic. Some argue it's become endemic as opposed to a pandemic. And what that may or may not mean in terms of payments for COVID vaccines that have proven to be very effective, and treatments for COVID that have also proven to be very effective. How will that change? I don't know, Ali, if you want to address that first.
Yeah, and I think it's something that, the administration is at least working to ensure coverage of vaccines and treatment for those on Medicaid and CHIP, and as well as Medicare. But one thing that, regardless of what HHS does, where there is state level decisions that could be affected, are these states were allowed to seek Medicaid disaster spas, which allowed them to implement temporary flexibilities to adjust for surges or just kind of adapt to the pandemic times. And a lot of states implemented disaster spas to allow pharmacies and pharmacists to provide COVID vaccines, among other childhood vaccines, as well as increase or set reimbursement for COVID vaccines at the Medicare rate, which was above what the vaccine rate would normally be. And all of those flexibilities ended today. Those disaster spas expire the day the public health emergency ends. And I know CMS is working with states and has been working with states to make some of those flexibilities in disaster spas permanent. And some of those approvals will be retroactive. So there's not going to be a gap in reimbursement or providers being able to be authorized to provide those vaccines. But if we've learned anything, especially already in the start of this unwinding, it's that not all states are going to do the right thing. And so we may see across the board kind of a disparity in terms of access to these vaccines.
Right. And the right thing, and probably the smart thing. I mean, if you're trying to prevent people from getting sick, if you're trying to prevent an increase in healthcare costs, these are proven preventative efforts and treatment efforts. It's much better to provide those resources. So I'm particularly concerned about people with no health insurance coverage, who it sounds like they may be out of the system here and a lot of people may not be able to access them, particularly that group. And again, if we have more than 15 million Americans, or up to 50 million Americans losing healthcare coverage, that's a significant number, 5 million of which are children. I want to turn the topic to telehealth, because a lot has happened during the pandemic around telehealth, that there's been a huge increase in its usefulness, and we've learned a lot in its use, and we've learned a lot about how useful it is, whether or not there's a pandemic going on or not, right? what we have found is that telehealth can be such a great resource for providing a quality healthcare at the same level as in person in many, if not most cases, particularly for people that have a hard time getting to a doctor's office, whether because they live in remote areas, in a rural setting, or even in urban settings because they have to get to their job, take their kids to school. And again, low-income families are impacted the most and can best benefit from the use of telehealth. However, what happens to telehealth now? Is it going to go back to pre-pandemic limited use, or are we going to allow it to continue to grow and be used as part of the whole healthcare system? So either of you can tackle that question if you like.
So I know in the state of New Jersey, we are somewhat fortunate that our administration has continued our telehealth parity until the end of 2024. And they are using that time, or should be using that time, to estimate and get the idea of what the return on investment is for telehealth and the telehealth parity. I know that federally, CMS has allowed for behavioral health services through telehealth to continue. So that's really great, but that's Medicare, right? For the most part, Medicare is the federal program, and so states are under Medicaid. So fortunately, again, for New Jersey, that continues until the end of 2024. And then after that, we will see. And so I think if you're not in one of the states that doesn't have such legislation, that is really a tricky question. And I'll look to Ms. Gardner to fill that in.
Yeah, no, and so a lot the Medicaid disaster spas that I just mentioned, states also utilize those. Probably that's what states use them most for, is for telehealth flexibilities. And I think what a lot of people didn't realize is states already had a lot of autonomy in terms of being able to implement telehealth and use telehealth in the Medicaid and CHIP programs. And they didn't need CMS approval. But where these disaster spas came in, and where states may need to seek permanent state plan, spas or state plan amendments to, and that dictates how states operate their Medicaid programs. Those state plan amendments are required when a state wants to implement differences between how services are provided in person and or reimbursed in person versus via telehealth. And that's where, to Dr. Ali's point, we saw a lot of states understanding the need for people who needed remote appointments and were not able to come into offices, reimbursing providers at the same rate as in-person services, as well as authorizing behavioral health, physical therapy, occupational therapy, all via telehealth during the pandemic and through these disaster spas. Again, all of those ended today, but if I've seen any state progress, a lot of it in terms of making those temporary flexibilities permanent, telehealth is the #1 spot that I point to. And I think a lot of states have seen an increase in access and utilization as a result of these policies, and hopefully we'll see that continue.
Right. I'm going to remind people that please write your questions in the chat. We're looking out for those questions. In the meantime, Ms. Gardner, I think that because we have people listening from different parts of the country, I wonder if you could put in the chat access to the website from the Georgetown Center, your center, because I found when I was going through that site, it was really helpful to understand the differences across the country and the dates of when things are happening. So if you can do that, it looks like Jennifer Baskerville did that for you. So thank you for doing that. Yeah, it's a really good resource. Really appreciate it.
Yeah, absolutely. And I'll say that resource is ever evolving. We call it our 50 state tracker, and really trying to keep a pulse on what states are doing related to the unwinding, what public facing materials they're posting. And most importantly, right now, where I would direct you to, if you look at anything, is the states that have unwinding data or data dashboards, because it can really be a first step in monitoring what's going on in your state, where there may be potential issues arising and consumers may need assistance in going through this renewal process.
Great. Thank you. Thank you. So we're getting a question, is there any sense what Arizona did that was successful versus what Arkansas didn't do? And I think that's directed to you, Ms. Gardner.
Yeah, that's a great question and something we're still trying to kind of unpack. In talking, we have advocates on the ground and have talked to people. I think one particular thing is, I think the state and the Arizona really enlisted stakeholder and community engagement. They are active participants in a coalition of about 200 people, where you have health plans, advocates, again, the state agency folks, sometimes Medicaid enrollees that all come together once a month to share what's going on. And this was an existing coalition that they've adapted to focus on the unwinding. And, you know, in pre-unwinding times, they use that to figure out what communications materials were resonating, what kind of outreach was needed, what kind of outreach dollars were needed. And I think that's a huge thing that a lot of states haven't looked at, is they've put most states developed communications materials. And I think this, to your question, is where Arkansas may have failed. Just because states developed communications materials doesn't mean those communications materials got to enrollees. And I think that's the key issue we're trying to unpack right now, is there doesn't seem to be that enrollee awareness that we thought there would be, given what states said they were doing in terms of outreach and putting up things on websites. And I think to all of this is, rural areas are going to need particular focus, because those kind of social media campaigns that states were doing, billboards, things on buses, all of those sounded great in theory. And I know it's something we promoted at CCF, but in practice, people in those rural isolated areas aren't seeing those, haven't seen those, and are really unaware of these changes. And the last thing I'll say to this is, Arkansas is an example, and other states have done this as well. As they continued to do renewals during the unwinding process, people were still getting notices in the mail saying you were found ineligible, or, you know, we need you to return this information. They would call the state Medicaid agency, and the state Medicaid agency would say, there's a disenrollment freeze, disregard your notice. Well, now we're 3 years later, and people think they're still supposed to disregard those notices. So I think in states where that's been a practice, there's going to need a lot more enrollee education and a lot more outreach for people to understand actions are now needed, and those notices are a lifeline to continue coverage.
All right. Well, I think that hopefully satisfied. It sounds like it did the question. There's another question coming up, and I think I'm the one that used the term gateway to refer to health insurance as a gateway to quality healthcare. What I meant by that, and Dr. Ali, feel free to add to this. What I meant by that is that it's a lot easier to provide quality healthcare or comprehensive healthcare, medical, oral health, mental health, and meeting social drivers of health or social determinants of health when one has insurance, right? And because healthcare systems and centers like yours, they depend on reimbursement for those services at a reasonable rate. And I know that you provide it regardless of ability to pay. That's one of the things you do really, really well. But it's hard to sustain that without people being insured. Do you want to say more about that, and even how patients might, access healthcare or not, whether they're insured or not?
No, that's an excellent point, and it's completely true. So it is easier, and it's easier for families and children to, again, have the entry or the possibility, the options of having quality healthcare when they have insurance. And as you said, as a health center, we do provide health care to individuals regardless of their ability to pay. That's what a FQHC does. However, that's only the services provided within our walls. And so many health centers only provide primary health care services. Some do mental and behavioral health care, some do dental care, vision care. But then what happens after that? And so even if we have the most excellent health center, which I think we do, then what happens when children and families need other services, when they need neurodevelopmental services or more advanced mental health services or more advanced behavioral health services or specialty care services? then we're in a real pickle. And that has been the issue we've seen throughout the years. And that is the fear of children losing coverage. That what happens to all the other services that you really need to wrap around a child and a family when they lose coverage. So yes, again, insurance is, as you said, the gateway to that. It's the beginning.
It's the beginning, right? Thanks. I'm gonna, because of the time, and the half hour goes by very quickly. I'm gonna start with you, Ms. Gardner. Just give a closing thought about, as you process this, as you're talking through it, and even hearing Dr. Ali and you're hearing each other. What's your final thought on this? And what's the message you want to send to our audience?
Yeah, I think the main thing is that the coverage losses are not inevitable. Even if people are ineligible for coverage, they can transition to other sources of coverage, whether that's the marketplace or CHIP. And so the coverage losses we see is going to be dependent on how well states do in preparing and implementing processes that reduce red tape and encourage people to help maintain enrollment, rather than just going about their normal processes and saying, we sent the notice. So it's really going to take an all hands on deck approach, a community-wide approach, and the state is important, but community partners are going to be essential, especially in states that we know are not as invested in kids' healthcare.
All right, I love that. The loss in coverage is not inevitable. That's a great message, but we have some work to do in particular parts of the country to do that. And Dr. Ali, your final thoughts?
Yeah, just echoing what Ms. Garner said, and what is our role in that part, in that process, because many of us are the community partners. And so how are we proactively reaching out to the other community stakeholders, to the state, to be a part of those discussions and those plans? Because as Ms. Gardner alluded to earlier, we are usually the trusted partners. We know what our patients need. We are on the front lines talking to them, working with them. And so that information, many of the states need in order to deliver a communication plan that really works for our community. So again, what is our role in really developing a process that works for our community?
All right. Well, I want to thank you, Dr. Ali, Ms. Gardner, for being here today and the work that you do throughout the year to serve people and to inform all of us about what we need to do and what we need to know to make sure that every child in this country has the best healthcare that they deserve and need to thrive and succeed. As you know, this work is incredibly important to us. At the Children's Health Fund, we proactively identify the most marginalized children growing up in under-resourced and hard-to-reach communities. And we partner with underground leaders like the Henry J. Austin Center and Dr. Ali to deliver the healthcare services they need and deserve. We hope you'll reach out to talk with us about how you can get involved and support this work. I really want to thank our audience for joining us today and asking them to reach out to us. And we hope you'll join us on our next Children's Health in Focus, when we will be discussing the long-term impact of disasters on the health and well-being of children. Please be on the lookout for an announcement that has more specifics, including the date and time of that Children's Health in Focus. So again, thank you all for joining us today, and thank you to our panelists for being here and informing us.
Thank you.
Thank you.